Hi, good morning, BU. Good morning, Vinod. Hi, good morning, BU. Good morning, Vinod. Hello, how's your Sunday going? So today we have 10 images to discuss, and in the evening again at 6 we have more images to discuss. Okay, so shall we start our images discussion? Yes, are people joining us? Good morning, Asco. All right, good morning. Okay, so we'll start with the first question. All right. A 1-year-old child was brought with complaints of right eye leukocoria. Fundus image is shown above. What is the most likely diagnosis? So first of all, a 1-year-old child. Oh, happy birthday, BU. Happy birthday. I will text you on the app. Yes, I will wish you again personally on the app, and I will you don't have a WhatsApp, right? So I will SMS you. Okay. Your question on the app, I have to reply. I forgot to reply. Okay. Okay, enjoy your day. Today is your birthday. Of course, get your parents' blessings, go to the temple, get God's blessings. Today, yes, you can afford to relax. Just watch our 3 sessions today. You're good to go. See, BU, everybody is wishing you. Happy birthday, BU. Okay. I'm not telling your name because I'm waiting to reveal your name when you get your rank. Okay. So, on our YouTube channel, you'll remain BU. All right. Okay. So, back to our question. 1-year-old child with leukocoria. Yes. Now, leukocoria is whitish reflex at the pupil. Yeah, whitish reflex at the pupil. Leuco means white. That's why we have leukoma, corneal opacity, which is absolutely dense and white. Coria means pupil. So leukocoria is whitish reflex at the pupil. See, normally when you look at the pupil, it looks blackish, right? Now, it is leukocoria because it looks whitish. So, there are a lot of differential diagnoses for leukocoria. I have told you. So, I told you the differential diagnosis of leukocoria is cream pint. 2C, 2R wala cream pint. Yeah. So, C, congenital cataract. Then another C is Coats disease. R, retinoblastoma. Another R, retinopathy of prematurity. E of the cream, endophthalmitis, typically a metastatic endophthalmitis because of septicemia. You have a focus somewhere else, infectious focus somewhere else in the body. Then A, astrocytoma of the retina, which is seen in tuberous sclerosis. Then M, morning glory disc. Then coming to the point, P, persistent fetal vasculature, popularly earlier known as PHPV, persistent hyperplastic primary vitreous. I, incontinentia pigmenti, that is part of McCune-Albright syndrome. Then N, Norrie's disease, and T, toxocariasis. Okay, toxocariasis, not toxoplasmosis, toxocariasis. Right. So this is leukocoria ka differential diagnosis. Now we have a 1-year-old kid. Now 1-year-old kid means a lot of things. It narrows down to a lot down, and we have an image also. So let's look at the image. So this is the fundus picture showing you the image of a lesion. So I definitely can see the optic disc way here. Okay, so this is involving the macula. So definitely not a morning glory disc. Definitely not Coats disease, because Coats disease you will have a lot of hemorrhages as well. Nothing here. So it is like a ball of cheese. It's like a ball of cheese. See, when you make cottage cheese at home, mummy makes, no, she puts in the curd, put the lemon juice, and then, because I also make, no, then you put it in the muslin cloth, and then when you take out, it's like that cottage cheese. See, it can be a shredded cottage cheese like that also, or it's like this. So this is retinoblastoma, typical presentation, that age 1 year. What is the mean age of presentation of retinoblastoma? Ask her 1 second. Let me finish this question and I'll read your comment, beta. So retinoblastoma, unilateral retinoblastoma presents at 18 months, okay, 1.5 years. And bilateral retinoblastoma presents a little earlier. We don't know about this laterality here, but I'm just telling you. Bilateral presents a little earlier, so 12 months. Okay, so these are the things you've learned. So this is a retinoblastoma. Okay, so this is a retinoblastoma. Yes, everyone clear on this? Leukocoria, retinoblastoma, and this fundus image also is clear. If you get it as a fundus image, Would you be able to answer? All right, Asko, you made my day. My Sunday is going pretty well. Amazing now. Vinod, I will discuss that some other day. Okay, I've noted it down. I'll discuss this some other day because Norrie's disease is kind of little not very important. So we'll concentrate on the important things, and then we'll see. We have a lot of time by the time we go for NEET PG or INI-CT. By that time, I will discuss one at a time. So all the differential diagnosis of leukocoria we will discuss. Yeah. So first, differential diagnosis itself is important. Retinoblastoma is important. Now, next image. Can we go to the next image? Yes? All right, let's see what this question is about. All right. So first question, let me also explain the other options. Okay, so see, retinal astrocytoma. See, retinal astrocytoma will look like, like beads, white beads, like pearls, no, like mulberry, white mulberry. It look like white mulberry. So that is out. Choroidal osteoma will look very calcific. It will be looking white. Morning glory disc, of course, it involves a disc. This image did not even involve the disc. This retinoblastoma, option is retinoblastoma. Okay, moving on to the second question. Which of the following clinical findings is or are seen in the left eye of this patient? Acha, now, although I've written it as left eye, now when I show you here, it will look like it is a right eye because it is laterally inverse. So, right eye. Okay, so that means the left eye is normal. Right eye, what are the clinical findings you're seeing? So, you got to tell me what are the findings you're seeing. So, this is like OSCE. What are the things that you're seeing? See, the patient has closed his eyes. Okay, he's been asked to close his eyes. His left eye is closing, right eye is like this. So, what are the findings you're seeing? One is the inability to close his eye, inadequate closure of this eye. What is a term for inadequate or incomplete closure of the eyelid called? Yes, put it in the chat box, guys. What is this? Lag ophthalmos. Excellent, Vinod. Yes. And very good. You're seeing lower lid ectropion. Why am I saying we are having ectropion? Beta, it's just not lag, it's lag ophthalmos. Okay, lag ophthalmos. See, lid lag is different. This is lag ophthalmos, and you're also able to see ectropion because the lower lid margin is turned outward, ताकि you can see the palpebral conjunctiva, right? So palpebral conjunctiva नहीं दिखना चाहिए ना? See, normally your eyelid is opposed to the globe, opposed to the eyeball. अब ये outward turning of the eyeball की वजह से you're seeing the palpebral conjunctiva because of the outward turning of the eyelid margin, ectropion, you're seeing the palpebral conjunctiva. So there is ectropion. So option 1, ptosis. Do you see ptosis? No. Option B, lag ophthalmos. Yes, we see lag ophthalmos, inophthalmos. Inophthalmos is a sunken eyeball. Okay, the eyeball is sunken. Yes, very good, Asko. Bell's palsy. So this patient actually has a Bell's palsy. Right. Entropion. Yes, entropion. No. So this patient actually has a seventh nerve involvement because of which there is lag ophthalmos and also an ectropion. So this is a paralytic ectropion. Yes. And his Bell's phenomenon also is bad. See, it's not gone up and out completely. Yeah. So poor Bell's phenomenon, then you got lag ophthalmos, then you got paralytic ectropion. Yes, Bell's phenomenon. See, Bell's phenomenon itself is normal. See, when I attempt to close my eyelid, because my facial nerve, thank God, it's normal. So when I close my eyelid and you open it, see, my eyelid has, my eyeball supposed to have gone up and out. I hope it's gone up and out. I hope I don't have a poor Bell's. Okay, so when you try to lift it, it's up and out. That is normal. That is Bell's phenomenon. Okay. So poor Bell's means when it is not going up and out. So you tell me whether it is an LMN palsy or up UMN palsy, you got a poor Bell's phenomenon. That's a question for you. Moving on to the next question. What is the most likely diagnosis? All right. So we've got an image like this. And they're asking us what is the most likely diagnosis. So can you see the image? So this is the cornea here, and we are seeing some kind of redness here. And I can see that there is a swollen up area. It's like a nodule. Can you all see that it is a little swollen up? Gundu gunda. It is like little motapan here, na? Can you all see that little thickening here? A nodule and a redness. Give me a thumbs up if you are able to appreciate what I'm showing you. एक मोटापन दिख रहा है? Yes, very good. Good. So, scleromalacia perforans. Guys, scleromalacia perforans, the definition is it is a necrotizing anterior scleritis without inflammation. No inflammation. See, remember, go back to your Robbins pathology. Pata nahi, aajkal you all are reading pathology or not. But let me tell you. Pathology, general inflammation, there is rubor, color, dolor, tumor. Okay, rubor, redness. Color, heat, the tenderness. Heat, when you touch it, there will be a heat. Dolor, pain or tenderness to touch. What is the other one? Tumor, swelling. Yes, that is inflammation. When you don't have inflammation in scleromalacia perforans, how can you have rubor? How can you have redness? In my image, there is so much of redness. So much of redness. How can you mark scleromalacia perforans? After attending my session, you should never ever mark anything red as scleromalacia perforans. Is that clear to everyone? Will you make that promise to me? Because it really pains me, when I see children marking scleromalacia perforans for this kind of question. I take it very personally. I'm like, बच्चे ऐसा मत करो यार, मत करो, okay? मैं ड्रामा नहीं कर रही हूँ, सच में it pains me. Okay, so please promise me, when you see some redness like this and a swelling like this, you will never mark scleromalacia perforans. Okay, now that's an order also. See, scleromalacia. Malacia means softening. Okay, it's thinned out. It's thinned out and itna necrosed and thinned out. Okay, it's soft. So it cannot be swollen up like this. Do you understand why you should not mark scleromalacia perforans for this? So out of 4 options, one option definitely ruled out. Okay, so from a 25% probability of arriving at the answer, Sida you have risen to 33%. See, my maths is very bad, but this maths is very good. Okay, this I understand very well because that is career defining maths. Okay, career deciding mathematics. From 4 options, when you have 4 options and you have no clue, whatever you mark, 25% probability of arriving at the answer. One you've ruled out, 25, Sida you've jumped 8%. So that means your rank is climbing up. Understood? So definitely not scleromalacia perforans. Okay, ma'am, answer to bata do. Option B, anterior scleritis. I think so. But anyway, I want to read the other options. Posterior scleritis. Man, I told you the definition of posterior scleritis is when the inflammation is behind the equator of eyeball. Where is the equator? From the limbus, 14 millimeter from the limbus of eyeball. So, matlab, it's quite posterior, no? Posterior scleritis. Why would you see this kind of, it would not be visible like this. Yes, there will be redness in the posterior part. There will be some scleral thickening in the posterior part. It will not be visible like this. So, it's unlikely to be posterior scleritis. Okay, option D, ciliary staphyloma. See, ciliary staphyloma will be bulging like this, but you will see the blue color. Why? Because the sclera is thinned out and you will see the underlying uveal tissue. See, redness may or may not be there, depending on what is the underlying cause. Okay, but you will not see the white sclera. You will see the blue sclera. You'll see a black. Yes, very good, Asco. Asco Lex. How do I call you? I'll call you Asco. Okay, you're my Asco. All right. So, what is your answer? Anterior scleritis. Sorry, not anterior scleritis. Okay. So this is anterior scleritis. To be specific, this is nodular anterior scleritis. Everyone agrees with me? Oh, as cool as are you? Oh, as cool. Oh, he is my as cool. He or she. Cool. He's my cool student. Alright. पता नहीं यार, दिख नहीं रहा सही से. All छोटा छोटा है ना. Everything is very small letters. I can't see. Matlab, I'm not concentrating on that. I'm concentrating on the teaching here. All right, as cool. Thank you, Vinod. As cool. All right, very good. So you saw an Ophthal OPD. All right, shall we go to the next question? You're going very slow today. What is the most likely diagnosis? Bapre, kya hai ye? See, that day, Vinod, you asked me a cause of exotropia, no? Ma'am, what is the cause of exotropia? This one, see, one eye is out. Divergent squint, exo. It is exo and it is a manifest squint, exotropia. One of the causes of exotropia. It's a neuro-ophthal cause. Okay, option A, internuclear ophthalmoplegia. Cavernous sinus thrombosis. Third nerve palsy. Fourth nerve palsy. Okay, it can be internuclear ophthalmoplegia. It can be because you get an exo, but you can get, okay, but the thing is, you see drooping. Do you see a drooping of the eyelid? Look at the palpebral fissure height. Palpebral fissure height means this distance between the upper lid margin and the lower lid margin when the patient is looking straight. Okay, that is palpebral. This is the palpebral fissure. Okay, and palpebral fissure height. Now, see the palpebral fissure height in the right eye and in the left eye. Is it decreased? So, there is a ptosis and an outwardly deviated eye, and definitely there is a downward displacement also. If you lift the lid up, you will see the downward displacement. So this is third nerve palsy. Yes, this is very good, Vinod. Third nerve palsy. Yes. So what are the 4 D's of third nerve palsy? Which is the third nerve, by the way? Oculomotor nerve. And oculomotor nerve is a purely motor nerve. Don't get confused by its parasympathetic impulse that it carries. Yes, it carries parasympathetic impulse. That doesn't make it a mixed nerve. Okay. Only if it supplies sensation to something, then it becomes a mixed nerve. Okay, because sensory and motor. So purely motor nerve, oculomotor, purely motor nerve. It supplies all the extraocular muscles except SO4 and LR6. SO4 supplies SO. That is superior oblique is supplied by 4th cranial nerve. 6. That is your lateral rectus is supplied by the 6th cranial nerve, the abducens. Okay. So that means when I have a third nerve palsy, what do I have? The 4 D's. I will have a down and out eyeball. Why will I have a down and out eyeball? Because the SO supplied by the 4th nerve, superior oblique, is primarily a depressor of the eyeball. Primarily a depressor. Okay, so that will make the eye go down. And the lateral rectus that gets spared. Why is it spared? Because it is supplied by your abducens now. Now, that means lateral rectus abduction. So that will cause the eye to go out. So you get a down and out deviation of eyeball. Now, when one eye is down and out and the other eye is looking straight. So one eye is looking straight, this eye is looking somewhere else. I get 2 images, double vision. So we get diplopia. I mean, the patient gets diplopia. So the 2 D's, second D over. First D was down and out deviation of eyeball. Second D was diplopia. Third D, of course, the the levator palpebrae superioris is gone. It's not working now. It's not innervated. So there will be drooping of the eyelid, upper eyelid. So the third D. What is the fourth D? The parasympathetic innervation to my sphincter muscle is gone. So sphincter is going to constrict the pupil. So its enemy dilator muscle will overact. So there will be a passive dilatation. So dilated pupil. Is that clear? All right. Yes. Yes. You're correct, Vinod. I mean, in case of divergent squint, you will have a heteronemus or a crossed diplopia. Very good. Now, moving on to the next question. An 8-year-old child was brought with complaints of pain and swelling of the right eye. So, in this case, I'll read it as a left eye. For the past 1 day, vision normal, extraocular motility is full, pupil is normal. What is the most likely diagnosis? So, you're seeing this kind of a picture. Left eye, there is a lot of swelling. There is redness. All right. Diana, I will come to your diamond. Okay, I'll come to your question later. I think every day you have a question here. Let me finish my quiz. All right, so let's see what is the most likely diagnosis of orbital cellulitis. See, it's not orbital cellulitis because the vision is normal. Vision will be definitely reduced in orbital cellulitis. And in my patient, Z ocular motility, the eyeball movements are full. In orbital cellulitis, some kind of problem will be there. So it's ruled out. And RAPD, pupil will be sluggish or not reacting at all in orbital cellulitis, which is not the case in my patient. So orbital cellulitis is ruled out. Option A ruled out. Pleomorphic adenoma of lacrimal gland. See, pleomorphic adenoma of lacrimal gland, yes, you will have a swelling like this in this area, but not this redness and pain that this patient is having for one day. This is a slow growing tumor. An 8-year-old child unlikely to get pleomorphic adenoma, but anyway, that is ruled out. Basically, it's a painless condition. Okay. Dacryocystitis. What is dacryocystitis, guys? Dacryocystitis is inflammation of the lacrimal sac. Where is the lacrimal sac? I've told you the tunky is here. Your water tank, the one which is secreting the tears, the lacrimal gland is here. The septic tank, which is collecting the tears, drainage is here. So it comes from here and drains here. Okay. So my lacrimal sac is in the medial wall of the orbit here, just below my medial canthus. So if at all I have dacryocystitis, I will have a swelling here, not in this area like shown in this picture. You see that? I would have had a swelling in this area probably if it is dacryocystitis, which is not the case in this image. So dacryocystitis is ruled out. Yes, cool student, correct. Cool student answer. No, Vinod. Yes, very good. Dacryoadenitis. Adeno means gland. Dacryo means lacrimal. So when I have a dacryoadenitis, I can have this kind of a little S-shaped swelling of the eyelid. Can you see the S-shaped swelling of the eyelid, bache? So it's a horizontal S. This part is more ptosis. There's a mechanical ptosis basically. Okay, there's a lid swelling. There's also a mechanical ptosis where you can see a lid being S-shaped. All of you get it? Give me a thumbs up if you understood all these findings that I've explained to you. So this is a case of dacryoadenitis. Shall we go to the next question? Alright, so this is an image. Identify the clinical findings seen in the above image. It's a very, very, very important image, guys. So this one, alright, badhiya, very good. So here you're seeing the dilated pupillary margin. So that's why this is all black. Okay, and this is a retro illumination. So the light is falling. Why is it orange? Because the light is hitting the fundus and the fundal glow you're getting as orange color, the choroidal orange color. Okay, because retina is transparent. And now I see the IOL margin, the optica margin. Can you see the IOL? And this is the dialing hole of the IOL to dial it, no? So this is the dialing hole. And what do I see? I see these glistening pearls. You see these nice shiny pearls, round cells. Do you see them? Yes, all of you, are you able to see them? What is this finding? What does the wife expect from that newly married husband? She wants pearls, Ellschnick pearls. Okay, so these are Ellschnick pearls. So after the cataract surgery is the wedding. After that, the painless complication is setting in. Okay, slow progress, painless decrease in vision. One fine day she says, hey, anniversary is coming. I need a pearl necklace. What pearl necklace? Ellschnick pearls. In fact, she is not even waiting for 1 year. She says, why? 1 month anniversary is coming. Oh, so the complication has set in. Most common complication after cataract surgery is posterior capsular opacification, and the most common type is your Ellschnick pearls. Yes. So Ellschnick pearls, very, very important. Yes, very good. Pseudophakia with Ellschnick pearls. That is a complete diagnosis. All right. Oh, I have not read the answers. Okay, option A. Ellschnick pearls. I'm so happy. Option A, Ellschnick pearls. I saw and I went and marked option A. I'm doomed. Why? Because I thought, okay, Ellschnick pearls. No, it's staring at your face. Option A. See, thumb rule is, because this is going to decide your fate. When you get your answer in option A, please kindly read B, C, D. because see, even now, even I was carried away because I didn't read the options. Option A, only when I saw Vinod's comment there, I thought, okay, there was something there in the option because I only said the question, I forgot. Okay, option B, pseudophakia with 𝐿-Schnick pulse. Yeah, that is a better answer, no? Because patient is having a PCIOL, which is pseudophakia, with the 𝐿-Schnick pulse, which is a better answer. Option B is a better answer than A, no? You get it? See, we are all correct if we mark A. We are all correct. We are not wrong. But in the whole schema of the universe, we are doomed to fail if we mark A. We are allowing Vinod to go forward, and I'm saying, hey, whatever 4 marks I've scored in some other question, 1 mark, I'm going down. So that means 1000 ranks, 1500 ranks, I would have gone down. Understood? So always read all the options. Get it? Yes. See, whatever, see, you cannot blame the system. We have too much population. We have to filter. So that's the only way we can filter. And that's the only way we can be the best. Yeah, you have to be the best. If you're my student, you have to be the best. Posterior subcapsular cataract. Array, how can you have cataract, man? IOL is there. There's posterior capsular opacification, also called as after cataract. But that is not posterior subcapsular cataract. Capsular phimosis, that is completely different. Yes? So the moral of this question is, if you get your answer in option A, kindly read option B, C, D. It doesn't cost much. Otherwise, it will cost your career, okay? Your dream branch. Alright, because I know most of you will not have your dream branch as Ophthal. You will have your dream branch as radiology. So let me tell you, your dream branch of radiology or dermatology, it will cost you, okay? I hope that puts fear in your mind. Because if I say dream branch of ophthalmology will cost you, you'll be like, man, no. Alright, next question. Hey, this one we discussed last Sunday also. Ophthal images decoded. So this should be very easy. So you see this dirty dandruff on the pupillary ruff. Pupillary ruff means this margin. So you see this dirty dandruff, gray flakes, and a little bit you can see on the anterior lens capsule also. So what is the diagnosis? Chronic congestive glaucoma, anterior uveitis, pseudo-exfoliation, pigment dispersion syndrome. I'm so happy most of you got this correct. Yes, pseudo-exfoliation syndrome. Yes. See, ideally we call it only pseudo-exfoliation. Syndrome is when the intraocular pressure is raised. You have a lot more findings. That is when we call syndrome. But yes, I've given the option as syndrome. Then it is pseudo-exfoliation syndrome. Alright, very good. Moving on to the next question. This image is also very important. What is this that you see here? What is this glistening thing that you are seeing here? Can you see one half circle here, one ring here, and another ring here? What is this, guys? Post in the chat box, put in the comments. The procedure, the question is not about what is. They are asking about the procedure is done for the management of, yes, very good, Vinod. It is intracorneal ring segment, ICRS. Intra-IC corneal ring R segments S, ICRS. Okay. Now, the commercial name is Intax or Kera ring or Ferreira ring. I always say Ferreira because Ferrero Rocher. Okay, anyway, the procedure is done for the management of Voigt's limbal girdle, Cogan's dystrophy, keratoconus, descemetocele. Among the 4 options, yes, it can be very good, Vinod. Absolutely. It can be done for high myopia. It can be done for keratoconus. It can be done for pellucid marginal degeneration. Yes. Now, among whatever I've taught you, the options, among the given options is keratoconus. So, yes, keratoconus. Voigt's limbal girdle is something like arcus senilis. Okay, something like arcus senilis, a peripheral corneal degeneration. Why I'm showing like this is, it is typically seen in the 3 and 9 o'clock. A white arc, Voigt's limbal girdle, you will see in the 3 and 9 o'clock position, peripheral corneal degeneration. Kuch nahi karna hai. You don't have to do anything for that. It is, okay. Cogan's dystrophy is an epithelial basement membrane dystrophy. It's a corneal basement membrane dystrophy. Descemetocele is a sign of impending corneal perforation. So this is ICRS, intracorneal ring segment. First FDA approved for high myopia, later and now it is done for keratoconus and also for pellucid marginal degeneration. Okay. Next one regarding cyanotophore slides. Which of the following pair of slides is used for simultaneous macular perception? See, when we talk about binocular single vision, BSV, Worth has given the grades of BSV. Grade 1, simultaneous macular perception. So that means when I'm looking at you, okay, I'm looking at you, both my eyes should receive the same image. Simultaneous macular perception, SMP, that is grade 1. And next one is fuse the two images, fusion, grade 2. Yeah. Grade 3 is adding the third dimension, the z-axis. So that is stereopsis or depth perception. So we have 3 grades of binocular single vision. The highest grade is stereopsis. Now they are asking about grade 1. What is the slide we use for grade 1? Okay, among these ABC slides, so you can see a cage and a bird. So when the patient has simultaneous macular perception, he will not report it as separate images. He will see the cage and the bird inside the cage. So this is the slide for SMP, simultaneous macular perception. Now this one is for fusion. So fusion, almost same image, but thoda sa dissimilarities, thoda sa differences. Like look at this bunny. This bunny, one bunny is having a bouquet. Probably it's going to propose to someone. And the other one already proposed and got the, and does not have the bouquet, right? Already the girl has taken it probably. So now if the patient has grade 2, that is fusion, so she or he, the patient will report as seeing a bunny with a bouquet. So we'll fuse both the images and report. So this is grade 2 ka slide. Grade 3, slightly disparate, and the patient will have a sensation of movement. Typically when you have a swing, you know, that swing, the angle of the swing will be different between the 2 slides. So the patient will add the brain when it perceives, if the patient has grade 3 BSV, binocular single vision, will add the third dimension and will describe as a swing in motion. Jula na, as the unjal aadra madri, okay, the jula is in motion, okay, is moving. Okay. Okay, so the answer in this case was option A, slide A. Next one, all right, a 10-year-old child is brought with a painless, slow-growing mass since the past 1 year. What is the most likely diagnosis? So this is the mass that we see in the upper and outer portion of the orbit here. They say it's a 10-year-old kid, slow and painless growth over the past 1 year. Now, how am I saying that this is the outer portion? Can you see the caruncle here? Caruncle is always the medial side. So this is the left eye ka outer portion. Okay, see, this is your caruncle. Do you get that? That little pinkish mass. And some of you look into that and say, "Ma, mera mass hai. Koi mass nahi hai. That is normal hai." Okay. So that decides whether it is a medial canthus. So you are seeing the medial canthus is on the lateral side. Now let's see what are the options available to us. Cavernous hemangioma. Guys, cavernous hemangioma is seen posterior to your eyeball in the cone. You remember the 4 recti? See, this is my eyeball. I have 4 recti getting attached. So behind the eyeball, you have the cone, no? Muscular cone. Within the cone, you will have a cavernous hemangioma. And cavernous hemangioma is the most common orbital tumor in adults. We have a 10-year-old kid. Completely ruled out. It's not going to present like a mass here. Dermoid cyst. I think so. Option C, osteoma. Osteoma, so rare. Okay, very, very rare. Lacrimal gland mass. See, lacrimal gland mass, yes, you can have it here. Okay, you can have it here. But 10-year-old kid, painless, slow-growing mass. Because in a kid, dacryoadenitis is quite common, but that is going to be painful. This is typically, you know, involving the rim. Okay, it's not, see, if it is dacryoadenitis, you will have a swelling which is pulling down the lid also. See, it is more, you can see it's very clearly here. Yes, so it involves mostly at the frontozygomatic suture. When do you get a dermoid cyst? During development, if some of the cells are trapped in the bone suture. So what is the suture we have here? We have the frontozygomatic suture. Yeah. So you can have a dermoid cyst developing there. That is a teratoma, and always rule out intracranial extension. You can have a dumbbell, 8-shaped tumor. You have an orbital mass and an intracranial mass. If it is just an orbital mass, yes, the orbital oculoplasty surgeon can remove it. If it has an intracranial extension, it has to be done with the help of neurosurgeon. Is that clear? See, very good. Oh, BU, super. Super. See, sometimes you can get a dermoid cyst here also, very rare. Okay, so this is more common. Alright, so we've come to the end of 10 questions, 10 images. Alright, so that's been a fantastic, fruitful day. And wish you again a very happy birthday, BU. Okay, so God bless you, do well. So evening 5 p.m. I will see you Fundus Walk. So join me on the Fundus Walk 5 p.m. and 6 p.m. we have our images decoded session. Whatever we did through the past 1 week, all the images we are going to decode. And FMG exam, I hope you guys did it well. Your exam well. So let's see each other at 5 p.m. Okay, 5 baje. Bye. Have a good Sunday, guys.